Hello everyone, I'm Pamela Lee from Hong Kong. I would like to thank IPOPI for the very kind invitation to me to give this talk on management of severe PIDs during childhood. The title is so fitting because really we need to know where do we stand in Asia before we can address this very challenging topic. So indeed, Asia is so heterogeneous. Asia harbors 60% of the world population, and 10 most densely populated cities are all located in Asia. Definitely the needs and priorities and the challenges vary geographically in our region. So coming back to PIDs, principles of management. So in a broad sense, immunodeficiencies in the inborn areas of the immunity, we've got deficiency in production of immunoglobulins or cytokines, so the strategies is to replace what is deficient, to regulate what is dysregulated in inflammatory and autoimmune sort of phenomenon. And it is so bad that the immune system is dysfunctional, we have to reconstitute it altogether. So these are the modalities. As I've mentioned, we can replace immunoglobulins or cytokines. There are an increased range of immunomodulators that we can use right now, apart from the traditional steroid immunoglobulins. Now we've got a broad range of biologics, mTOR inhibitor, and also the JAK-inhibitors. So reconstitution, classically, we do it by bone marrow transplantation or hematopoietic stem cell transplant. And of course, nowadays we have the option of doing gene therapy. So the general considerations are, we would protect the patient as much as possible by prophylactic antimicrobials or GCSF in case of neutropenia, providing protective isolation, especially in scenario of SCID. We prevent infection by precautions against the exposure, and also, of course, to avoid live vaccination in the severe T-cell disorder, and prompt action by providing a contingency plan and also specific patient care pathway, which I feel is the most challenging in Asia. There are gaps where the patients can fall through the cracks, including availability of treatment and drugs, accessibility to specialist service, and also affordability of all these expensive sort of range of services and medications. So this is a wonderful paper talking about the needs of immunoglobulin treatment in primary immunodeficiencies. Here, the keyword is latent therapeutic demand, which is defined by the underlying demand that represents how physicians would prescribe treatment, that is immunoglobulins, and how patients would comply if ample supplies are available and affordable, and the access of treatment is not a problem, and is only based on evidence-based clinical need. So you can see that the box and whisker plot shows the interquartile range for the probability distribution of the latent therapeutic demand of CVID and XLA, the two conditions which immunoglobulin therapy is mostly used in PIDs. So you can see that in North America, so the latent therapeutic demand is the highest, whereas countries in Asia, like Japan and China, they're really in the lower end. So what determines the latent therapeutic demand? So it's an equation mainly contributed by the number of patients and also the treatment volume per patient. And that together will constitute the demand for immunoglobulins. So what would be the immunoglobulin demand in the Asian context, and what are our considerations? So firstly, the prevalence, the number of patients. We do not have formal data. We really need a registry in order to tell us the number of patients and also the disease categories. In terms of A-gamma globulinemia, so XLA outnumber autosomal recessive A-gamma a lot, okay, perhaps with the exception of countries and also population where there are a lot of consanguinity. So otherwise, XLA constitute more than 80–90% of those with A-gamma. And CVID compared with the Western population is much less common in the Asian context. However, we are facing a challenge of increasing number of patients diagnosed and treated as a result of improving awareness and diagnostics. Most of them are young patients right now, but definitely they will grow up, and therefore with the increase in body weight, they will have increase in immunoglobulin usage. And well, that is the ideal scenario for the calculation of the LTD, but really in the real life situation, a lot of financial constraints would impact on the treatment rate, treatment compliance, the treatment dosage, and also the frequency, and therefore affecting the actual volume to be delivered to the patient. And so there will be discrepancy between the latent therapeutic demand and also the actual demand right now, and it is so dynamic. Currently, it is estimated that the actual usage of immunoglobulin is far lower than the real need, that is the LTD. So now that is the demand, let's go to the supply. So these data are obtained by the MRB, the Market Research Bureau, so projecting the IG consumption by region from 2010 to 2026. You can see that North America is the leading sort of consumers of immunoglobulin, and the rate of increase in the highest in terms of the slope. So for Asian Pacific, it is really very close to the increment in Europe. So the challenge is here. So even in the United States, the FDA has already announced the shortage of immunoglobulin. So with such an increment and also already facing a shortage, it will lead to a problem of shortage in the rest of the world, because while North America perhaps has only got 9 fractionation plants, it constitutes 35% of the global fractionation throughput, whereas in Asia Pacific, so although we house 60% of the world population, we are only generating less than 1/3 of the global fractionation throughput. And you can see that although we have a lot of fractionation plants, but each of them perhaps are relatively small scale, and also the efficiency is less compared with North America, where they are processing the plasma rather than the blood donors in order to get the immunoglobulin. So therefore, there is really a lot for Asia and Pacific to catch up. And for the immunoglobulin consumption, so we can see that Asia Pacific is almost like doubling up, okay, in terms of projection till 2026. But at the same time, North America and also Europe, they are also fast growing in terms of the IG consumption, and therefore the plasma requirement. The reason for that is mainly because of the increase in demand for secondary immunodeficiencies. And so as a result of more number of cases of cancer and also other treatment that would lead to secondary immunoglobulin deficiency. So the factors influencing the per capita consumption of IgG include diagnosis and indications, the pricing and reimbursement policy, influence of patient groups and public awareness, market structure, manufacturers, promotion activity, and off-label use. So while the leading IgG consumption in the world, okay, from the North America, Australia, and also the more advanced economy in Europe. So in Japan, Korea, China, and Singapore, still it is much lagging behind, and not to say the developing economies in Malaysia, India, and also Thailand. But the demand is fast growing. So from data that we can see from other marketing research, so China in the past decade has grown 3 times increase in IgG usage, and also in Indonesia and also other countries like South Korea. So with a fast growing sort of demand, and also with the competing sort of indications, so this is something that we will need to tackle. So more PID patients are being diagnosed because of a lot of good work to promote the awareness of PID by IPOPI, CPID, and also APSID. So more physicians are aware of these patients. And with better care, these patients are having longer life expectancy and therefore increased number of years on immunoglobulin. There would be better geographical accessibility and also financial accessibility as a result of policy change in reimbursement, and also better physician education. But in terms of supply, so if we are not able to pump up the domestic product and still rely a lot on important products, and so the sufficiency of domestic plasma collection is still not yet able to sustain the local regional use, and we need to improve our efficiency of plasma fractionation and also to ensure resilience at times of demand surge. For example, in COVID-19, when other emerging indications are coming up, and also reduce in supply of the imported products, and also reduce in supply of the plasma supply. So the big challenge is how to ensure adequate provision is made for PID patients in the context of competing demands for immunoglobulins. So now coming to other sort of treatment like cytokines and also the biologics. So this is again another very good review article on the mechanism-based precision therapy for treatment of immunodeficiencies, and in particular in the context of immune dysregulations. So there are many biologic and also the targeted therapy coming up that will benefit patients with primary immunodeficiencies. However, most of them, they are licensed for other diseases, especially the rheumatological disorders. So they are mainly used as off-label use in PIDs, and therefore in some countries, they may not be covered by reimbursement or insurance. So the patients will need to bear the cost out of their pocket. So what are the opportunities? So here in Asia, we are really having a lot of development in terms of biosimilars market. So you can see the number of biosimilars in clinical trials, they are catching up with those that are happening now in North America and also in Europe. So what would be the future? So as a result of increasing number of genetically defined PID patients in Asia, mostly as a result of our whole exome sequencing, that we are able to locate the genetic defect and therefore providing the opportunities to use the targeted treatment, better physician knowledge in PID management, increasing patient expectation and demand for precision therapy. So we are really looking into an increase in use in biologics and also targeted therapy. However, the challenge will be unavailability and also the high cost of biologics that are the reference drugs. But in Asia, how to embrace the opportunities brought about by the growth of biosimilar markets that PID physicians would need to embrace and also to expect and also to get prepared, so would be something that we need to think about. So now, reconstitution, bone marrow transplant, and also gene therapy. So when the immune system is really so bad, perhaps we really need to think of replacing it altogether. So there is a growing list of indications of transplant for PID, and there is an opportunity for cure, not just replacement or regulate, but really to cure the disease altogether as a result of improved transplant outcome because of better matching, the opportunity to do haploidentical transplant, supportive care, cellular therapy, and graft engineering, especially in the context of haplotransplant, better technology in terms of drugs and also drug monitoring. So really, more importantly, is how to create the pathway for patients to reach to the stage of getting a successful transplant. And I would say out of all the indications, SCID is the most challenging. And it is really a test of the medical healthcare system of how successful it is. So really to improve the outlook, the outcome of patients for SCID. So firstly, the first step is to reduce the time from the first infection to diagnosis. And we need improvement in awareness, recognition, early referral, and also a clear referral pathway. We need expedited diagnosis, expedited transplant preparation, readily available donors, and in order to enable a timely transplant, the age of transplant is a critical determinant of the outcome of patients with SCID. And also better technique in the transplant in terms of minimal toxicity, no minimal or GVHD, and early immune reconstitution. Altogether, the most critical thing is awareness, policy, patient care pathway, and a seamless service coordination and integration between immunology and transplant service, which is again lacking in our region. So well, transplant is really up in the pyramid in terms of all the services required are provided for the pediatric population. But while Great Ormond Street Hospital, a world-renowned hospital, providing primary immunodeficiencies care and also transplant is celebrating its 50th anniversary. So do we really need that time in order to attain that level of skills in order to provide cure and also a ray of hope for our PID patients who are really in need of this life-saving procedures? So well, example from Hanoi, so which we have been collaborating for a long time. So this is a family who has lost 2 boys already because of X-linked SCID. So with the 3rd child, so mom is already having a very good sort of recognition in terms of the early signs of SCID, and therefore at 2 weeks, mom already rushed the baby to the National Hospital of Pediatrics. And so with our collaboration, so we diagnosed X-linked SCID, confirmed the mutation for the boy. So we urge the Hanoi team to really consider transplantation because the baby is not infected and is in the most optimal state. So with a lot of discussion and also a lot of support, so Hanoi team proceeded with the first transplant for SCID in Hanoi, in the whole country of Vietnam, and also the first haploidentical transplant in the whole country. So they use an unconditioned transplant because that is of the minimal risk, excellent cell dose, and so they provided very good care, and it was really successful. And then we visited the family when we had our first EPSI school in Hanoi 12 months after transplant, and we are also happy about this very successful story. So another even more challenging case, so they attempted the first CD3, CD45RA depleted haploidentical transplant for SCID, a procedure which is normally only undertaken in the most advanced transplant service in advanced countries. So this is a rectal SCID, so typically without conditioning, so it is very difficult to engraft. The patient has already infection on board. So in Asia, most of the haploidentical transplant are performed by the post-transplant cyclophosphamide approach, unmanipulated. However, there will be increase in toxicity, which we consider this patient will not be able to tolerate. So we advise to have graft engineering. So with support from the Singaporean team, they perform the CD3 and CD45 depleted transplant, a lot of technological support from the Clinimax company as well. So they did all these with the support from the company and also with the Singaporean team. So they infused the graft, and also we performed the myeloablative conditioning. Again, it is a successful transplant, successful engraftment. The patient is off immunoglobulin. The whole transplant was so smooth without any major toxicity. And I would say this is almost like a perfect transplant. I cannot wish for more. So apart from all these, I think the number 4P, I would say, is perseverance. Again, is something so important that we are able to save SCID patients who have undergone ECMO with the most sort of stormy clinical course in the PICU, and then ultimately we're able to save the child, the journey to cure a normal life. You can see that this is the girl who have just finished a transplant, is about to discharge, and she is one of our biggest advocates in our PID patient group promoting the World PI Week 2 years ago. And this is her going to school. So without the perseverance, perhaps we won't be able to see these wonderful patients being able to go to school and to survive. Another wonderful story from Singapore. Again, I'm a rare patient. So he has been to the PICU for multiple times, underwent multiple rounds of resuscitation, almost lost her life because of the H-like syndrome, a lot of organ sort of dysfunction. But again, the Singaporean team was so persevere, and that they are performing the transplant for twice, and then ultimately with this very lovely little boy together with the family. So these are really the heroic stories that we hear all over from Asia. Gene therapy. So right now, we don't have gene therapy in our locality. Is the future not too far away? Are we able to perform here in Asia, or do we still need to send the patients over to other countries? So this is again something we need to think about. So this is a patient from Hong Kong with Wiskott-Eldridge syndrome. However, unfortunately, he has got a very bad gut inflammation, and there is no match donor, and we do not really want to risk a very bad gut GVHD by performing a mismatched transplant. So we contacted Great Ormond Street Hospital with the great help from Professor Adrian Fresher. This is perhaps one of the first patients, if not really the first few patients from Asia receiving gene therapy. And again, very successful. Our fellow at that time, Dr. Kai Chong, was receiving training in Great Ormond Street, and she was with the patient at that time throughout the gene therapy. Again, now he is 2 years post gene therapy, sustained high level of gene marking and also the Wiskott protein expression, and brought to cure with very minimal toxicity, a very safe procedure. And this is something that we have a lot of perseverance in order to do the best for the patient, the best available in the world. So this is really the summary slides. What are the needs, priorities, and also challenges? The learning curve is very steep. Okay, so we are trying to overcome the steep learning curve, but we hope that we do not really need to go through all the things that Europe and also North America has gone through in the past few decades in order to reach the highest level of service and also the treatment for our patients. There are a lot of challenges we need to overcome, but we need to recognize the needs and also to set priorities and also to seize the opportunities. So thank you very much.